Hello, everybody. Nelson Virgil here with ExcelMale.com and DiscountingLabs.com. I'm very honored today to have one of the top urologists here in Texas. He's in Dallas, Dr. Andrew Sun. He's actually in Arlington, the north of Dallas. Dr. Sun specializes in men's health, focusing on issues such as erectile dysfunction, Peyronie's disease, low testosterone, post-prostate cancer recovery, and testicular issues. He went for undergraduate at the University of Maryland, medical school at Harvard, residency at the Cleveland Clinic, and the fellowship at UCLA, the Male Reproductive Medicine and Surgery at the University of California, Los Angeles. So welcome, Dr. Sun. Very honored to have you here. And today we're going to speak about Kyzatrex and oral testosterone in general, trying to demystify the myths and misconceptions about oral testosterone, since we had a product many years ago that was liver toxic. Now we're going to talk about the new paradigm and the new products coming through, approved by the FDA. This one was approved, I think, in 2021, 22. So Dr. Sun, welcome. And he's going to give us a lecture on a PowerPoint, and hopefully we can ask him a few questions at the end of the PowerPoint. So welcome, and thanks for joining us.
Yeah, thank you so much, Nelson. This is an honor to be here with you and your group. Thank you for the very kind introduction. I am a urologist, and I basically exclusively practice in male sexual medicine. We have a large urology group here in Dallas, Fort Worth area called Urology Partners of North Texas, within which we have a men's health center, and that's kind of what we run. So it's a pleasure to talk to you guys today about this new product, or let's say new-ish product. And yes, oral testosterone, although I'll get into why it's almost like an interesting way to say that because of exactly what you mentioned, the misconceptions behind the term when you use a catch-all term like oral testosterone. So I'll just go ahead and get started here, and feel free to interrupt me with any questions or anything, and it should be kind of a fun conversation. But I have some slides, at least, that I'll kind of go through with some data to kind of bring up the high points. Every pharmaceutical presentation is always going to start with some sort of disclaimer. The indication and black box warning from the FDA is always something to mention. All testosterone products carry a high blood pressure sort of warning. There are variations of how big of a high blood pressure difference that is, but that is still the case with this testosterone. And then in print so small that it's hard to see, there's all of the other things that follow with testosterone. This is the state of the FDA label today for all testosterone products. We will talk more in detail about these specific things, but those are kind of the standard disclaimers, right? So I wanted to talk about the history of testosterone broadly, as by way of an introduction. Testosterone was first synthesized in about 1935, and once they synthesized it, they tried to say, what way could we get this into humans, right? And the easiest oral administration route was thought of first, but in order to get the testosterone to get through the liver and into the bloodstream, you had to methylate it. So methyl testosterone, which is what we used to basically say when we said oral testosterone, we meant methyl testosterone, was very, very bad for the liver, and lots of problems, and so that was taken off the market. And unfortunately, that has left a residual sort of bias against oral testosterone, because when you say that word, what you're actually talking about is the old methyl testosterone. The new oral testosterone agents are a completely different modification of that. They don't go through the liver, and so they don't have those liver toxicity issues. So what we still have, what we mostly have are testosterone injections, right? Depot testosterone first in 1979. Now there's like lots of different esters that you can use as an injection, cypionate and anthate, propionate, whatever you want to use. The topicals came out as a way to get the testosterone in the system without the injections, but as most urologists and most patients will probably attest to, most people don't like the topicals. They have high variability in how well they work and how well they absorb. They can be transferred onto others. And so that was always there, but never the most popular thing. One of the more interesting things to come out in a while was Natesto. Natesto is a hyper short-acting 3 times a day nasal gel. It's not a spray, it's a castor oil gel that you basically put in your nose, and it absorbs very quickly. And the interesting thing that came out of that data was that you could potentially, using a fast-acting testosterone, give testosterone replacement therapy while still potentially preserving endogenous testosterone production and therefore possibly fertility. So that was really interesting. Zyostat is just an auto-injector pen that delivers testosterone enanthate in an easy-to-use form. And then finally, in 2019, we had a new version of oral testosterone, that's testosterone undecanoate. Testosterone undecanoate has been used in other formulations. There's an injection version of testosterone undecanoate called Avid here. It's like a 10-week injection. But the oral TU basically came out in 2019, and now there are 3 versions of it, Kyzatrex being the most recent one and the one that we're going to focus on today. And so I actually kind of like to say it as oral TU or oral testosterone undecanoate, because if you just say oral testosterone, a lot of people will immediately default to methyl testosterone, which is a very different compound with a very different risk and safety profile. We don't have to belabor this. Everybody here knows that testosterone is low T is common. It's way more than even this estimates at 4 million men, especially because the definition of low T, while officially, depending on which society guideline you follow, is 300 or 350. Most of us know that many patients can be quite symptomatic with low testosterone, with total testosterone values well above those hard and set cutoffs, right? So Kyzatrex is a twice-a-day dosing. That is how it's initially invented and prescribed. There are 3 doses of it. They come in 100, 150, and 200 milligram capsules, and all of the primary doses are 2 capsules twice a day. So 4 pills a day divided into 2 time points. So therefore, you're either taking 400, 600, or 800 milligrams. And the astute observer will notice that these are very, very high numerical numbers compared to, say, an average injection dose, which is 100 to 200 milligrams a week, let's say on average. And that's because subcutaneous or intramuscular injections are definitely significantly more bioavailable than the oral. The oral passes through and is absorbed lymphatically, but it's a relatively smaller percentage of that total dose that is being absorbed into the body. So that's why the numbers are so high. You do have to take it with food because this does not go through first pass metabolism, right? It's not going through the liver. It's getting absorbed directly into the bloodstream through the lymphatic system in the intestine. In order for that to happen, the lymphatics have to be sort of turned on, which means you do have to have some food with it. If you're completely fasting, you can still take it. It's just not going to absorb nearly as well. So what are the advantages of oral TU versus other versions of testosterone? Well, definitely from a safety profile, a lot of the common things that you see with, say, injections are mitigated. We'll kind of go through those more in detail. There's a lot of different doses, similar to injections. You can titrate them. And the blood pressure increases are very, very small. They're there. They're there, especially in select groups of patients. But overall, compared to other versions of testosterone, they are much smaller on the scale of things. So a lot of it is just about side effects. And there also are some interesting things with the pharmacokinetics that we'll kind of get into in terms of ways that you can customize a testosterone regimen with this. Because it's a twice-a-day dosing, there are different things that you can play around with that to achieve certain effects. This is just talking about the lymphatic absorption. It's a phytosterol ester is compounded into the capsule. A phytosterol ester is basically something that helps it absorb, and it also has some lipid lowering properties, and so we'll look into that data. But essentially, it's testosterone undecanoate, and then it's absorbed directly into the bloodstream, so it bypasses the liver, and so it's not liver toxic, right? I can't say that enough.
Dr. Sun, a question.
Yes.
About food. Do we have to have a certain amount of fat content in the food?
It's a good question. And I think that, well, there's a slide later that will have some data for it specifically, but the answer is it does not appear so. They actually studied low fat, medium fat, high fat diets, looking at the bioavailability and absorption, and they're seemingly about the same. Now, if you ask me, does that mean that I can take a celery stick and a Kyzatrex pill? I would probably eat something a little bit more substantial than that, And for a lot of guys that take the morning dose, but they do intermittent fasting, either they do like a scoop of peanut butter, or I have a guy that does it with a shot of olive oil or something just to get things going. And yes, you would assume that those would be fattier things just to get the system going. So very great question. Effectiveness, I've personally never loved this slide because it depends on what you determine as effectiveness. Now, from the FDA standpoint, effectiveness is to meet a certain threshold, C average, but that is may or may not be symptomatically effective for everybody. In this case, 96% effective, meaning you can get the patient to the right number. You may have to change the dose, and I'll show you some dosing data in a second. But you can definitely achieve those serum levels as you want to with this medication. This is one of the more interesting graphs. This is the pharmacokinetics of this medication, right? So remember, this is a twice-a-day medication. And so when you do a clinical trial and you submit data to the FDA, if you have a 24-hour medication twice a day, you're going to take it 12 hours apart. You're trying to prove a C average over time. And so this is all patients at the end of 90 days of being on the study. Now, all patients on the study started at a dose of 200 milligrams twice a day and then titrated up or down depending on their dose requirements. And so this is the 90-day mean for all of those patients, irrespective of dose. And so it's definitely averaged out, but there's definitely you can see the sort of max for some patients is closer to 1,000. And so, when you're looking at averages, remember that those are averages across all doses, but, you can have C maxes that are definitely into the thousands. And in my clinical experience, I can see some patients who are super absorbers and, 1,500, 1,600, those kinds of numbers are achievable if the right dosing regimen is used. In this scheme, you can see that basically the peak is within about 3 to 5 hours after taking the medication. And then it slowly kind of tapers off so that about at hour 10 or so, it's mostly gone. And another interesting observation would be that if you take these medications at time point 0 and time point 12, then theoretically you are getting this little gap period, right? Where like the testosterone falls back low again. One of the things that I've learned in my clinical practice is, and part of the way that I think about this version of testosterone is, can I more accurately recreate and boost the naturally occurring circadian rhythm biology of a patient by timing the testosterone doses in such a way that they get the testosterone during the times that they naturally would have higher levels and need it, and not have it during the times that they don't need it, which is to say the middle of the night, which is normally when your system is producing your own testosterone. So, the official dosing essentially is AM and PM. But I will tell you that a lot of my patients have instead of a sort of 6 a.m., 6 p.m. dosing, they do more of like a breakfast and after lunch dosing schedule, right? So the breakfast dose kind of recreates that peak of testosterone that you normally have naturally in the morning. And then what do most patients complain of? They complain of being tired at 3, 4, 5 o'clock in the afternoon. So that lunchtime or after lunchtime PM dose gives you that extra boost of testosterone 3 to 6 hours after the administration. So if you take it at 1, then it's happening at 3, 4, 5, 6, 7 o'clock. And then they report that they get home and they still have energy and they feel like they still have, an evening ahead of them. But then that dose has mostly worn off by 10 o'clock at night when they're ready to sleep. And so there are definitely some patients who actually report that by dosing the testosterone this way, it almost helps them regulate their sleep cycle because they have done their testosterone in a way that naturally mimics their circadian rhythm. And I have guys that'll use it almost to correct jet lag and some of these kinds of interesting things that I've noticed over time. Right? So that's part of the customization of being able to take it twice a day, as opposed to saying having a flat or at least slowly declining testosterone level all 24 hours a day, which is what you get with a long-acting, injection or something like that, or pellets or those kinds of things. So lots of interesting stuff there. Next slide is the fat content, right? So this is that same pharmacokinetic curve, but red low fat, blue normal fat, and green high fat, showing that it's mostly basically the same, right? It doesn't seem to affect it very much. And so I just tell patients, eat it with something maybe a little bit substantial, but it doesn't, you don't have to be counting your macros for this particular thing in terms of how you're going to absorb, the drug. Here's some interesting data on hormone parameters, right? So we'll go through these one by one. I know, anytime there's a slide, you'll look at all of them at once, but one by one. Top left, bottom left is free testosterone and SHBG. So as I know this group is very, very knowledgeable, but I'll just have to go, say it. SHBG, right, binds total testosterone. Some portion of their total testosterone is available as free testosterone. Free testosterone is more biologically active. It's the thing we actually should be looking at, but because of the way it's mostly calculated and not a direct measurement, it's a little bit less accurate unless you do equilibrium dialysis measurements. So we mostly use total testosterone in our clinical guidelines, but arguably free testosterone is much more important. So if you can lower the SHBG, then you have liberated preferentially more free testosterone for any level of testosterone that you get. And what's really interesting about this drug is that it lowers SHBG. There are other oral agents, similar agents that do have SHBG lowering effects, like oxandrolone, right? But in this case, this is the only testosterone replacement therapy that has been shown to lower SHBG levels. Therefore, you get more free testosterone preferentially. I have had these patients where they come in, their total T is 450, and their primary care doctor said, you're normal, like, don't worry about it. But they don't check the free T and the SHBG. So we checked those things, and this guy has an SHBG of like 90. So his free T is actually garbage, even though his total T is 450. We put him on Kyzatrex, even at a modest dose, and his total T is still 450. But now his SHBG is like 22. And so his free T is much higher, and he feels like $1,000,000, even though his total T, if you just use that metric, has stayed the same. A lot of interesting things. On the right side are FSH and LH, the pituitary hormones. Most patients who take testosterone injections over time will have what? Testicular atrophy, unless you use HCG to counter that. And basically a decline in the FSH and LH to essentially almost zero, azospermia, meaning not making any sperm anymore, and essentially your own system is shut down. I think that the theory is that if you expose the body to testosterone 24 hours a day, 7 days a week, and it actually never goes down, then your brain never sees a period of time in which there is a low T environment to tell itself to make some more testosterone by secreting FSH and LH. With this sort of breakfast and lunch dosing scheme, or even with the 12 and 12 scheme, because there are periods of the day in which the body is still sensing that low T environment, I believe that is why that these patients seem to maintain some degree of FSH and LH secretion, even though they're on testosterone replacement therapy. Now, that does seem to be dose dependent, right? The higher the dose, the more suppression there is. That's generally universally true with any form of testosterone. But that definitely has some interesting ramifications. We saw this with Natesto, but 3 short-acting peaks throughout the day. What about 2 somewhat longer peaks? What about 2 peaks that are pushed together, but then leaving the nighttime where you naturally normally make your testosterone, leave that part alone, and let your body still kind of maintain its own production. So it's really cool. One of the if you see this data, then your next question is, well, do these guys still make sperm? And so there's a study ongoing about that, and I don't have the results for you yet, but we'll be able to report that sometime, hopefully in the next year. So I know I'm spending a fair bit of time on this data, but I'm sure it's interesting, and I think lots of cool things. So we'll breeze through the rest of it, which is basically, yes, patients feel a lot better. A lot of my patients tell me that they feel much more even on this. Not every version of testosterone is for everyone, but for a lot of people, especially first timers, people who are adverse to needles and that kind of stuff, this offers a very, low safety risk and good efficacious way of doing testosterone. In terms of adverse events, so every testosterone version, there's always high blood pressure. And then if you look at that, the hemoglobin increase, right? The hematocrit, like the polycythemia rate, it's about 2%. That's in contrast with injections where it's 30, 40% at times. And that leads to a lot of downstream ramifications. There are a lot of men who, understandably, they take a high dose of injection and then they donate blood extremely frequently. And that sounds great unless you check their ferritin levels and their iron levels, and they're extremely iron deficient because you just cannot replete your iron stores as quickly as you donate. And so, I'm, as a sort of physician in my practice, I'm trying to find a way to manage these guys low risk, still get them what they want in terms of feeling good, but have, reduce that risk of adverse effects. And so the hematocrit thing is a significant advantage. Liver data. So there was no clinically significant change in the mean values for the LFTs throughout the study. No trends over time in the percent of subject participants to have greater than like the upper limit of normal for most of these liver function tests. There was one study patient who did have elevated FTs, and he withdrew from the study. I checked LFTs in the first 20, 30 patients just because I was like scared about stuff. And in the normal guys, I never saw anything. Sure, if I have a guy that comes in and he's like in fulminant hepatic failure and has a liver transplant, like maybe I'll be a little bit cautious just because I still don't 100% know. But in general, I'm very, very confident about the liver safety of this because it doesn't actually metabolize through the liver, right? Here are some average blood parameters for those patients at 6 months. So PSA usually goes up a little bit, right? If you're starting below saturation threshold, it'll go up a little bit. Hemoglobin goes up 0.5, right? It's very, very minimal. And then all those metabolic factors, they get better. Cholesterol, triglycerides, insulin. I mean, that's part of my practice is trying to get more physicians to understand that low T is not just about bodybuilding. It's not just about like getting huge. It's a component of metabolic syndrome. And so much of our society is sick with metabolic syndrome, right? Diabetes, high blood pressure, high cholesterol, obesity. And if we count testosterone as part of that whole picture, oftentimes, almost always when you see that guy, it's going to be low, and fixing it does a lot to help them on their journey for getting healthier overall. And so that is what we see when we treat these patients with low T, right? It's helping their overall health. The blood pressure data, if you really break it down, it's mostly in patients who are already having high blood pressure, already taking medications. So 1.7, percent overall, or sorry, 1.7 millimeters of mercury, right? But it's a 3.4 in those hypertensive patients. And you can see the diabetes patients are almost quite there. So those are probably the guys that are going to get a few points of blood pressure increase, although it's definitely less than other forms of testosterone. And then here is the titration guide. So remember, the initial starting dose per study is 200 milligrams twice a day. On the graph on the right is where all the patients ended at the end of the study. So only 22.6% of them actually ended up at that initial dose, right? If you add the 300 and 400 BID columns together, that means like 70% of the patients ended up being at a higher dose than that. And so when I looked at this data in my clinical practice, I just start people at the higher doses, right? Initially, I started everybody at the 300 BID because I was like, well, that's where most people end up. And I saw very little safety problems. The patients did really well. And 80% of them were like, hey, doc, I'm feeling good. Can I take the 400 BID dose instead? And I would say, sure, why not? And so I just ended up there. And so now most of the time, I just start most people at 400 BID. Like I just get them the dose that I think it's going to work. And as long as I've proven safety at that higher dose, then I already know that at lower doses, they will also have safety, right? So it gives me my checkpoint immediately. It also gives me a test of efficacy immediately. I don't want to be spending time like, does this work? Does this work? Does this work? Do you feel better yet? Do you feel better yet? I just want to, if it's going to work, it's going to work. And if it's going to be a safety issue, it's going to be a safety issue. And I just know that up front. So that's just how I do it. But again, officially 200 BID is the starting dose. So I think this is the last slide. And basically, what's interesting about this, right? The safety, these less blood pressure increases, the significantly less hematocrit, erythrocytosis problems, the fact that it's liver safe, the fact that you can basically customize your dosing scheme in a lot of ways based on both the dosing and the timing. The FSH and LH, potential for preservation and fertility preservation, the free testosterone and SHBG effects, very, very interesting. And I think it's one of the newer, it's one of the versions of testosterone that has come out that has really allowed us to change the way that we treat patients. When we just had, say, injections and pellets, then everybody mostly got that. And variations would be like, do you inject twice a week versus once a week? And of course, there are some people still doing it every 2 weeks, which like doesn't make a lot of sense biologically, but people do it. So anyway, that's kind of a summary of oral testosterone undecanoate, right? I'll use the full name. Kyzatrex is the formulation that I prefer. It's the easiest to get into patients' hands. It's got easy to remember numbers. There are two others, Jatenzo and Talando, and we can talk about those, but basically this is what I generally prescribe. It's just a lot easier for a lot of patients. And that is pretty much it. And this is QR code, I think, takes you to their website if you want to learn information, but we'll open it up for questions, I guess.
Yeah. Thank you. Great presentation. You're a great speaker. Dr. Sun, yeah, and by the way, I'm going to include all these links in the comment section, in the description of the video on YouTube and ExcelMale. And we can stop sharing. Maybe that's probably easier.
Sure. Yeah.
A bit to
okay.
keep, question. I have, I'm taking it. Just wanted to share my experience. Because I don't like talking about anything unless I've taken it before.
Sure, yeah.
I have tried. Yeah, I think I have tried every single option to write my 2 books. And I was curious about the liver thing with Kyzatrex. I tried first to go through my insurance. It was basically pushed back. And because I was using injections, I was using 100 milligrams a week. But I wanted to try just to see, especially when it came to the hematocrit numbers. I wanted to see water retention and blood pressure, because I've been on testosterone for 37 years. I'm one of 65 too. So, and a little too, my BMI is still a little too high for my own good.
I
But
think
anyway,
all of us would be that, yeah.
Right. So, but my total is 800, and my free is I always go by percent, 2.2%, which is actually very good for me. I was under 2%, which is really the kind of the cutoff.
Yeah.
What is the best free testosterone? You go for it by total, multiply by 0.2 and picograms. But anyways, so it's been good. I mean, I'm also somebody that has a lot of, like, I have an IBS, so I was worried about that a lot. Is it gonna make me bloat more? There are two. I basically take the 800 milligram dose, 400 milligrams twice a day. I do take it right after lunch, the second dose, like you said, because that makes a lot more sense to me.
Yeah.
Obviously, I've had my LH and FSH suppressed for 30
Yeah.
years.
Yeah.
I'm not planning to have kids, obviously. So that I'm curious. So having checked my LH and FSH, I'll probably do that on the next set of labs. So far I'm kind of impressed because no bloating. That's my first thing. No acid reflux because it's a GI. You're taking it through your mouth. Hematocrit is at 50, which is good for me, stable. I'm usually a stable guy when hematocrit. I've only donated twice in my life, and the lipids look good. Most testosterone, if you go up in dose, will decrease the good cholesterol, the HDL.
Yep.
Barely. I don't have that problem. So far, I'm pretty impressed. Kidney function is fine. My eGFR is like 90. So I see it as a safe product. The access issue, and I want to talk about it because that really is, for me, when I tried to get it a year ago, or maybe longer, I just got frustrated. My doctor did too, and we stopped.
Yeah.
So it wasn't until I started talking to you guys and I found out a way to actually access it. So talk to me about how to get this drug without having to go through a nightmare of insurance pushback.
Yeah, so I'll talk about that from two sides. There's the physician side and there's the patient side, right? So I'll speak to it first from the physician side. I think the one thing that every doctor and every patient can probably agree upon is that we all hate insurance companies. If you've ever been to the doctor recently and they were like spending 5 minutes with you and like they were just running around and it feels like, there's not much personal touch anymore and like they're all haggard and it takes forever to respond to messages, it's because this is a longer thing. It's because that our physician reimbursement stuff is like set by the government and it basically hasn't changed since 1998. And so I don't know that many other people that make the exact same amount that they make in 1998 as they do today. And the problem is that over time that the insurance companies just add more and more and more and more paperwork that, essentially they expect us to do. And yes, we're happy to do it to a point, but it becomes really onerous and it's really challenging when you have to see all your patients a day. And at the end of the day, you have like this gigantic book of like authorizations and calls and like you have to talk to somebody on the phone, but they're never on the phone and you have to do all this stuff. It's a huge, probably the number one most hated thing for the physicians is also the prior authorization stuff for testosterone. And because ultimately insurance companies get to decide what we get to do, we're just sort of handcuffed by what they allow us to do. So that's been an issue. That's been an issue for a long time with any branded testosterone product. Obviously, testosterone cypionate, fine, easier, right? Lots of ways to get that. And so when Jatenzo, the first oral TU in America came out, that was what it suffered from, was that it was very difficult to actually get the access. And so Kyzatrex is interesting because when they came out, they specifically said, we are going to a direct cash pay model. We don't take insurance. We don't contract with insurance. You can get Kyzatrex for cash and that's it. And it basically cuts out all of the paperwork that we have to do. And it also cuts out all of the wait time that like the patients have to do and the back and forth and everything. And so there are a variety of distribution models, they could talk to you more in detail, like in terms of the company, but basically you can't get it at like CVS. They have limited their distribution in the initial phases, I guess, of the rollout of this drug. So a lot of it is being done through some telehealth platforms. And then a lot of it is being done through large, like urologic, what we call IODs or in-office dispensaries. So like here in Texas, we have a pharmacy that's attached to our practice. And essentially Kyzatrex is available in our pharmacy and it's a cash product. And so I basically, most of my patients get it that way, or they get it through a mail order pharmacy in the mail. I send it to a pharmacy. They basically mail it out to the patient, but it's all cash. The average price is about $160 a bottle. A bottle is a 1 month supply. And so, it's not like the as cheap as testosterone cypionate, but because of all of the like sometimes I have the guys, they're like, wow, cypionate's a lot cheaper. I'm like, yes, it's true. But if you have cypionate, you might have to go donate blood. So that's like, let's say 4 times a year of taking time off. You might have to take some anastrozole. You might start having some hair loss. So you might want to start taking finasteride or something, minoxidil, whatever. You might want to take HCG if you don't want your balls to shrink. You're like adding up all of these other things. Or you can take this pill and you can just pay cash and there you go. And ultimately, you know, it's at the end of the day, like after I see a patient, we both just want the drug to be in the patient's hand as quickly as possible and with as little paperwork as possible for both of us. And that's what's been really helpful about Kyzatrex from a model standpoint.
So the ideal or the average or medium patient that you prescribe this to, is there a pattern? Is a
Yes.
younger that want to keep their testicles functioning for
Yeah.
although we
I
don't.
have all versions,
Yeah,
and I'll give you a few different sort of case scenarios, right?
yeah.
So, case scenario one is a guy that's been on injections for a while, not like 200 or 250 or something like that a week. Those guys, like, I'll just be straight up honest with you. If you're above 200 milligrams a week, or especially 300 milligrams a week, it will be difficult for any other version of testosterone to recreate that exact experience, right? Area under the curve, everything like that. That is high. Most of us who practice urology and do, you know, general medicine, most of us, we start at about 100 milligrams a week and go up or down from there. Rarely down. Some people are very sensitive, but, you know, probably your most of your ranges are between 100 to 200 milligrams a week of testosterone cypionate, right? Some of those guys, they get polycythemia, they have like blood pressure issues, they have to donate blood a lot, they have that whole ferritin being low and recurrent blood donation thing. So sometimes those are the guys, and I tell them, hey, you know, we could try this other thing and we might be able to save some of those side effects. And I definitely put all those guys on 400 BID right away, right? The highest dose. They tend to do well. They tend to correct their hematocrit issues. So I usually see them, they're always riding like 52, 53, and then they don't donate blood anymore. They just change over to the Kyzatrex and they're like 49, 50, you know, it just makes me feel better. There is some thought that, you know, why does, you know, when do you convert excess testosterone into DHT or estradiol? You convert it when you have high sustained total peak testosterone levels, right? And so if you ride a really, really high level for a really long time, you're probably going to have a lot of E2, so anastrozole, and a lot of DHT, so propecia, finasteride, or you'll have, you know, balding or gynecomastia or like all this stuff. Because Kyzatrex's peak is, it can be as high, but it's not as long lived. It does not seem like they convert, or they essentially it's, and I can't exactly explain this to you in biology terms, but they don't seem to have enough time to convert those things into other products. And so I have not nearly seen the same amount of hair loss or gynecomastia or basically estradiol elevations in these patients. Even when I'm checking their labs at peak, they don't get these like huge E2 numbers. So sometimes those guys, we try it out. The younger guy who wants a little bit of a boost, but doesn't want to go on something super suppressive, might want to have kids in the future, you know, kind of needs a little energy, mostly in the afternoon. Mostly is, you know, everything else is working okay. That guy, I think of this as a nice little gentle first introduction to testosterone. You know, I do male fertility. I see a lot of guys that have taken a lot of testosterone and nobody ever told them that they would stop making sperm. And then they come in and they're like, I have no sperm. And I'm like, I think I know why. So, you know, I like it in those younger guys. We still use a lot of clomiphene and enclomiphene in the younger guys. When I have somebody that's really trying to have kids, you know, I'll usually stick to those, HCG, anastrozole, enclomiphene or clomiphene. As anybody who's taken clomiphene will tell you, maybe they feel better, maybe they don't. You know, half the time it works a little bit, half the time it doesn't. Numbers look better, they don't feel much better. So I actually use Kyzatrex in those guys as almost like a rescue medication. And so I can give them both clomiphene and Kyzatrex. And essentially their FSH and LH stay at the pre-clomiphene baselines, right? So it's like FSH, LH, and T, and then on clomiphene, numbers look better, FSH, LH, T, but they don't feel better. Give them the Kyzatrex. The T is still good or better, but and the FSH and LH come down a little bit, but it same as baseline, and so they still preserve spermatogenesis. So that's what I'm taking is clomiphene. I also, like you, Nelson, I don't like to prescribe stuff if I haven't tried it myself. Mostly, right? I haven't tried all the versions of testosterone, of course, because I still want to have kids. And so I basically do a clomiphene plus once daily Kyzatrex, and I take that once daily at lunch because I wake up in the morning, work out, I feel fine in the morning, but it's that afternoon, getting through that afternoon clinic is tough. So that's where my daily lunch dose helps out a lot. And, it seems to work out well for me, right? So that's one man's experience, but got a lot of patients who kind of do the same thing.
Thanks a lot. I mean, it's always good and refreshing to hear from a clinician, somebody actually prescribing, seeing patients, because nothing is black and white. There are different protocols. There are variations of protocols. I may not follow the label 100%, but you are actually adapting to the patient. And that's something that some doctors don't understand. They just go by label, and
Right.
they don't customize for the need of the specific patient. Every man is different,
For
So
sure. For sure.
yeah, so I'm interested. I mean, you guys are actually going, well, the company is going to produce more data on sperm. I guess there'll be
Yep.
more data on hematocrit also.
Yep. Data on sperm, data on hematocrit, data on what happens if you start everybody at 400 BID, right? What are their C average and what are their peaks? I have done some of that data myself just because looking at my patients, and it looks like I would say about 800, 850 is the C average when you start at the 400 BID, with range that goes up to like really high 1600, and that goes down to like 500. Yeah, I think I've really enjoyed the last year and a half or so, because this drug has essentially opened up a lot of opportunities for, as you say, customizing and fine tuning these kinds of regimens. And I think especially in the male sexual health world, there's a lot of things that we don't have explicit FDA approved drugs for, but we have to kind of work around it and do what we can to help our patients. And yes, so I always will speak to the label, because that's the official stance, and I want everybody to know what the label officially says. But there are lots of things that a lot of people will do with their medications, and they have led to some interesting results.
Yeah, or some people stop taking them because you stuck to the label so much and they didn't respond. So I see that a lot. I mean,
Sure.
obviously, everybody has complaints, goes to
Yeah.
ExcelMale.com. So obviously, I see a bias sample of a problem.
Sure.
And lastly, you see this as oral testosterone, or less oral TU. I like
Yeah.
that when you said that, because every time I post something I have a Facebook group of like 28,000 guys. Every time I post something there on oral, they go there. The first thing they start saying, "Don't take it. Is toxic."
Liver.
I
Yeah.
guess there will be some kind of effort for some more education, because this is, like you said, we had a bad taste in our mouth from the
Yes.
40, 50, 60 years ago with methyl testosterone.
Yes.
And that is a barrier that most
Yes.
people are afraid. Even when you say oral testosterone, they think about supplements or something OTC you buy on Amazon. So it's really important to keep doing this work. I think we're covering enough ground, you would think, right? So
Yeah, no, totally. Yeah, it's been very, very interesting. I love talking about this. It's definitely a passion of mine. And then thanks for allowing me to come on and talk to your group. It's really cool. And I think, like I said, not every version of tea is fit for everybody. But this is a huge addition to our arsenal of different testosterone formulations. And there are many patients whom it's the perfect fit for, right? I have a lot of different types of guys who take a lot of different types of testosterone. But it's been a really cool addition to that group. And there's a lot of fun stuff that we've learned from it.
thanks a lot for having the time to explain this. I know this is the end of your day of 35 patients or so. So thank you so much. And hopefully we can have you again to talk about fertility. A lot of guys are interested in HCG and
Yeah,
promising data and things of that nature that there are lots of questions on that. So thanks
sure.
a lot, and hopefully we'll have you soon, and you have a good night.
Absolutely. Thank you. You too.
You too.